So I was pretty interested in a recent podcast that Scott Weingart and Josh Farkas did where they talked about ventilating asthmatics. And there was a bit of a debate on whether or not asthmatics can't expire or can't inspire. And I wanted to just give my perspective and get into the weeds of basic physiology as I usually do, and use the Campbell diagram to help illustrate respiratory energetics in people with obstructive airways disease. So this is the foundation of the Campbell diagram. If any of you have seen my lectures before, you know that here the x-axis is pressure, 0 is atmospheric, positive is above, and negative is below. And the y-axis is volume, and here I've illustrated as often done with the Campbell diagram based on percent vital capacity. So your functional residual capacity is roughly a third of your vital capacity. Just to make the math easy, we can say that a normal-ish vital capacity is 4.5 liters. So roughly a normal FRC would be 1.5 liters. So if you were to plot the compliance curve of the lung, it would look a little bit like this. So how could you do this? Well, an example is you could put just a pure lung in a bell jar with the trachea exposed to atmosphere, and if you were to evacuate atmosphere from around the lung to lower the pressure around the lung, the volume of the lung itself would start to rise, and it would do so as a function of its stiffness, which is illustrated by this curve here. So there's, for a given change in pressure, there's a change in volume defined by this compliance curve. And you can do the same thing, exactly the same thing with the chest wall. It's a little bit strange to think, but you could do a lungless chest wall, and you could actually start evacuating air from inside that chest wall and changing its volume. And what you can see in this relationship is that when the lung is exposed to atmospheric pressure, it tends to recoil to a smaller volume, whereas if just the chest wall is exposed to atmospheric pressure, it tends to increase to a greater volume. This is the equilibrium volume of the chest wall and the equilibrium volume of the lungs, respectively. And for any of you who've seen surgeons open a chest, say during open heart surgery, you've probably seen this before. When the sternum opens, the chest wall recoils outwards and the lungs tend to recoil inwards. And when they oppose each other in life, the chest wall is compressed from its equilibrium volume, and the lungs are increased from its equilibrium volume, and they meet here at functional residual capacity, which is slightly subatmospheric at this volume. And that's marked by this dot. So this chest wall curve is a bit esoteric. It is the pressure-volume relationship of the chest wall when it's resting. So you can sort of think of it as chest wall diastole. And in an analogy similar to cardiac physiology, there's a time-varying elastance. So when somebody takes a breath in, the characteristics of this wall change, and one of the chest wall changes, and one way you can envision it is like this. So you take a deep breath in, the muscles of inspiration are activated, and it moves up the lung compliance curve, and you move from functional residual capacity to this increased lung volume. And what you can see is this dotted line. This represents the pressure that the muscles must generate at that given volume. So to achieve this volume on the y-axis, the muscles of inspiration had to produce this much pressure, and here and here. So you can see to get to this higher volume, you had to drop the intrapleural pressure a certain number of centimeters of water to obtain this new volume. And so that's for a given volume. But what I hope to elaborate in a little bit more detail is that the area that's bounded by the pressure volume curve actually represents work in joules, and joules over time is power in watts. Nevertheless, the work is important. So that's what I've just said. This represents the pressure that the muscles of inspiration must carry out. And so if you look at the equation of motion, when you look at the total pressure for any given volume, so if you look at this volume here, the total pressure that the system has to develop is equal to the volume achieved divided by the compliance of the respiratory system. And you can sort of see that here, that as the volume goes up in the numerator, the pressure has to increase to obtain that volume. It might be a little bit less clear how the respiratory system compliance mediates that, but the way you can think of the respiratory system compliance is the difference in area between the chest wall curve and the pulmonary curve. And I'll illustrate that here. You could imagine a situation where pulmonary compliance gets worse and it shifts downwards to the left. Now to achieve the same volume, a greater pressure must be generated. So the chest wall would have to activate all the much more to create that volume. And then you can see that the work, the area in this shaded triangle, has also increased. So volume has stayed the same. Pressure has increased. So if this has stayed the same, but the pressure applied has increased, we know that the compliance of the respiratory system has dropped. And in this situation, it's driven by lung compliance. If you had a situation where the chest wall was stiffened, or if it was shift rightward, say from obesity, then a very similar principle applies. You could see that for any given volume, the amount of pressure that must be generated by the muscles of inspiration increases. Again, for the same volume and increased pressure, you know that the compliance of the respiratory system, or the difference between the chest wall and the lung compliance curve, has decreased. So if we go back to end inspiration here, we can sort of think about the energy or the pressure that must be applied by the ventilator by just thinking how much pressure or energy has to be applied above atmospheric pressure, and it's going to be equal. So you could look at this particular volume. To achieve this volume here, this much pressure had to be generated by the muscles of inspiration. So for the ventilator to achieve that same volume, the same amount of pressure would have to be applied, but above atmospheric pressure. And the same for this volume, and the same for this volume. So you can see that the compliance of the respiratory system, as I mentioned, is the distance between the chest wall and the pulmonary compliance curve, is actually traced out here above atmospheric pressure in this light blue line. So that's the pressure that the ventilator must deliver if this patient were passive. And you can see that in this patient who's on zero end expiratory pressure, or ZEEP, that this pressure change that occurs here is the driving pressure. If you're to do a plateau pressure here, this would be the plateau pressure. We'll get to that in a second, but this represents the driving pressure, and it just flows from the distance between the chest wall and the pulmonary compliance curves. So if we go back to our baseline at functional residual capacity, I've only really told you half the story because there's an additional amount of pressure that must be applied by the muscles of respiration to drive gas flow, or the dynamic component of respiration. And so when the chest wall muscles activate, there's actually this additional amount of pressure in red here for each level of volume on the y-axis. And that's defined in the equation of motion as the flow, which is the V dot, times the resistance of the respiratory system. So if the flow increases, or if the resistance of the respiratory system increases, then the pressure component here is greater. And that would be important in obstructive airways disease. And just moving back to the analogy with the ventilator, you'd have to apply that same amount of pressure on the ventilator to drive the dynamic portion of gas flow when you're ventilating a patient who's passive. So if we were to turn this portion of the graphic into a clinically familiar waveform, what we would do is move pressure from the x-axis. We'd move volume from the y-axis down to the x-axis, and volume can become time only when flow is constant. That's key. Flow has to be square wave, because when flow is constant, the same amount of volume is being delivered per time slice. So volume and time become linear analogs, and so you can equate them on the x-axis here. So we just make this mental flip. We can add a little bit of PEEP because that's what we're clinically used to. And you can see that the respiratory system compliance curve is redrawn here with the driving pressure between the two red dots. And that is, the blue is the elastic component of pressure or work, and then the red is the dynamic portion of pressure or work. And if you're to do an end inspiratory hold, as you often do, you get the peak and the plateau pressure. So that's how these concepts are related. So now I'm going to get into the obstructive physiology a little, hopefully somewhat quickly. So what happens during dynamic inflation? Let's go back to our baseline here. So with dynamic hyperinflation, it's predominantly driven by expiratory flow limitation. So there is a problem with the patient not being able to expire the volume completely. And what that does is it increases the volume on the y-axis here. And what this does is now when you start your next inspiration, you're starting from this higher volume. You're not starting from functional residual capacity. And you might see that in order for flow to occur, you've now got this pressure load that you have to overcome before flow can be generated. And as you've increased the volume here on the y-axis, and as that gas is being trapped in the lungs, it's creating a PEEP or an auto PEEP. And just how much PEEP that is generating by that trapped volume is actually the same as what we just talked about. It's just the reflection here above atmospheric pressure. So if this were a ventilator rather than the patient, him or herself, creating dynamic hyperinflation and positive end expiratory pressure, the amount of pressure that the muscles of inspiration would have to add would be equivalent to this here. So for this same volume, the dynamic hyperinflation and the auto PEEP that's being generated is actually right here. So that actually represents your intrinsic positive end expiratory pressure if you've got dynamic hyperinflation up to this level. And so now when this patient inspires, the chest wall moves leftwards here. Actually, there's no flow while the patient is overcoming this pressure load, or another way to think about it, as the patient is overcoming this entire workload, the area of this triangle here, before gas flow occurs. So now you're breathing at a higher lung volume, and these patients tend to have higher resistance. Interestingly, when you breathe at a higher lung volume, it tends to lower the resistance. The dynamic work of breathing tends to get a little bit lower as you breathe at higher lung volume, so it's a trade-off. But now this patient is breathing at a pretty high lung volume. So you can see that the energy that it took for this breath was this energy in this triangle to overcome the auto PEEP, and then the energy within this dynamic portion here, this red portion. But as you might guess, there's also the static portion of pressure and energy that must be generated at these higher lung volumes. And you see at the higher lung volumes, the chest wall and the lungs are stiffer, so the compliance of the respiratory system is less at higher lung volumes. So there's a greater elastic pressure or a greater elastic energy that must be generated at these higher lung volumes to breathe. So you can see that the energy for this breath is this component plus this component plus this component. So this patient, because they have dynamic hyperinflation, because they cannot exhale, they actually also, Scott was right, have a hard time inspiring. And the inspiring is because of this, the difficulty inspiring is because of this greater workload that's placed on the muscles of inspiration. You could imagine that if chest wall compliance was shifted down and to the left, or if the patient was obese or had problems with lung compliance was shifted down, or if the chest wall was shifted rightwards, that the energy required would be even greater. So what the application of end expiratory pressure does, or expiratory positive airway pressure, or CPAP, if you're to set it to say roughly 80% of the intrinsic PEEP, now the ventilator actually takes over this energy here. The energy to the system is being offloaded by the ventilator. And so now the patient actually doesn't have to overcome this threshold load before the patient can get the inspiratory breath in. So now in this situation, the work is, the pressure in the work is just this red portion plus this blue portion, because setting the EPAP has offset that inspiratory threshold load. So if you wanted to completely take over the work of breathing for this patient, what you could do is you could consider that the pressure and the work to achieve this tidal volume breath at this volume over here is a summation of the dynamic components in red and the elastic components in blue, and you can just flip that to the right side of the y-axis, so put it above atmospheric pressure, and that's the pressure and work that the ventilator would have to deliver for this breath here. So if you were to do a end inspiratory hold on this patient here, you'd start at a, well, if you dialed in the EPAP, say 6, and you did an end inspiratory hold, the plateau pressure might be, I don't know, close to 12, and the peak pressure might be a few centimeters of water above that. So if you dialed in an IPAP of, let's say, 15 or so, you would now roughly take over the work for this patient entirely. So that would represent the pressure or the work in the shaded blue above the added EPAP. And so now, when this patient inspires, the patient essentially has all of the work of breathing being applied externally by the ventilator. Now you can see, had you just applied IPAP but no EPAP, the IPAP only kicks in when the patient triggers the breath. So the patient would have to overcome this threshold load here, this area that's absent, which is roughly equivalent to this green shade here, that is offset by the EPAP. So if there was 0 EPAP and only IPAP, the patient would still be responsible for that triggering work. So that the EPAP is really important when patients are triggering with obstructive airways disease, because the EPAP, you can see, offsets that threshold load before the inspiratory breath is initiated. So I hope that makes sense. In summary, the primary pathophysiologic event is that patients with bad obstructive airways disease, particularly patients with bad asthma, can't expire, and they get dynamic hyperinflation. And because of the dynamic hyperinflation, they therefore, quote unquote, can't inspire because of the threshold load that's placed on respiration, and because of the greater energy that is required to breathe at higher lung volumes. Now, you can see here that I've depicted the volumes as being relatively high. So if this is functional residual capacity at 30% or so, and the chest wall equilibrium volume is roughly 60%, that's almost an additional 1.5 liters of volume above the functional residual capacity. And so a patient like this would be approaching what's considered severe dynamic hyperinflation. And in one study, they found that from end inspiration to functional residual capacity, if 20 cc's per ideal body weight in kilograms was expired, that was pretty severe asthma. So if you say a 70 kilogram ideal body weight times 20, that's roughly 1.5 liters. So that would be approaching a doubling of the FRC. So that would be pretty severe asthma. But I think that you can appreciate from this diagram that as the dynamic hyperinflation progresses, that threshold load is placed upon the respiratory system, and it does make inspiration more challenging for the patient. And that would tend to occur long before the patient was way up here in the dynamic hyperinflation and suffering from that so-called stone chest that Scott and Josh talked about, where the dynamic hyperinflation is so severe that you can't bag the patient, you can't get any gas into the patient on inspiration. That would tend to occur. One would expect that to occur certainly above 60% or 2/3 of your vital capacity. But the dynamic hyperinflation does start to play a role energetically at much lower levels of dynamic hyperinflation. I think that's all I've got to say. Thanks.